All right, well, thank you very much. I've enjoyed the session so far, and I want to thank Dr. Berman and the Research Foundation for having me speak, particularly because in my professional career as a neuro-ophthalmologist, I find treating patients with blepharospasm and hemifacial spasm really to be some of the most rewarding days of my clinic. So we all know that eye closure and blink, as you've heard today and may have known before today, is due to contraction of the orbicularis oculi. And although in the community of blepharospasm, we sort of grown to hate eye closure, we do have to remember that it's appropriate and it's done for maintenance of your tear film, and it keeps the eye safe. But as you're all too familiar with, inappropriately, when it's stereotyped and when it's synchronous, and we have benign essential blepharospasm. So I'm going to present a little bit about the development of benign essential blepharospasm in a different manner, but it is very consistent with what you've heard here today. And I'm going to talk about a two-hit hypothesis. This really represents sort of the G and M portion of the formula you heard from Dr. Hallett. And I'm going to specifically talk about things in a limited fashion. And so, but this by no means is any different than what you've already heard, which is their brain pathways that reorganize or become hyper-excitable. We don't really know exactly why that happens. Next year, we'll hear from Dr. Berman and Dr. Hallett with the answer to that. And then that part won't be so confusing. But once we do know, we also need to consider the other side, sort of the G plus M, which is there are environmental triggers. And I've only listed eye surface disorder here because that's what I'm going to be speaking about. So next, again, we have environmental reasons to close our eye. And everybody is aware of noxious, whether it's perceived or real stimuli, that results in eye closure in people with and without blepharospasm. Bright light, we've heard a little bit about photophobia, strong wind, smoke, particles like dust and debris in the air, very important for eye closure. So much so that even young girls here on a class trip to Quebec in the Montreal sun had sort of a temporary form of blepharospasm, unable to open your eyes in that condition in order to take your photograph. We've all experienced that. So it can be a normal response. And what about eye surface disease? We see the same thing. We see eye closure. We see frequent blinking because the local environment, you might say, is noxious. There's inflammation in the front of the eye or dryness that causes you to blink. And so I'm going to specifically be talking about dry eye and blepharitis just because of their contribution to blepharospasm is known and understood. But there are other eye disorders that I won't be speaking about that can also contribute. Includes keratoconjunctivitis. And I won't be talking about that. It just becomes more complex. So I'm going to stick with the dry eye and blepharitis. And there are many associated causes for these conditions: allergy, inflammation, infection, along with other causes that often overlap these two conditions. So medications, sometimes medications that you're using to treat your allergies, the environment, like here in Colorado, the dry climate, but also in your own home if it's very dry and not humid, and then certain skin conditions. So we'll talk about those. One thing I want to mention before I go on, though, is there are reasons to close your eyes that we just spoke about, but the following eye conditions are not reasons to close your eyes. And we get this question frequently. How about cataracts, macular degeneration, glaucoma, my diabetes affecting my retina? Does that make me close my eyes? And that is not the case. So we've also heard about the blink reflex, and just for a little bit of review, we know that there's a sensory component and a motor component we've heard. And the sensory component is the trigeminal nerve. And that sensory component is responsible for sort of surveying what's happening at the surface of the skin. And there are three main branches to the trigeminal nerve that survey. The most important for blepharospasm is the ophthalmic division or the ophthalmic branch. So anything that stimulates in and around the eye will go through the sensory route of the trigeminal nerve, end up in the brainstem, and then importantly signal to the motor nerve or the facial nerve, and I'm only showing one branch here, and cause the eye to close. And just to give a little break with a little movie here, I'll show you an example. We have a dust particle, gets in the eye, the trigeminal nerve gets triggered, sends a signal to the brainstem, the eye blinks. And that's all appropriate. You don't want more particles in your eye. You don't want more of that noxious stimuli. And we've already heard a little bit about what a potential pathophysiology could be. And so I'm just going to give you an example of a one hit. Let's say you have eye surface disease, particularly when it occurs between the ages of 40 and 59. That's just an example here, a little cartoon of eye surface disease with red eye, inflammation of the eyelid. And now you're going to get an altered blink reflex. You're going to have a stronger facial nerve response, a stronger trigeminal response, but particularly trigeminal. And there is plasticity that's appropriate in that response. You want to increase your tears, for instance, if you have dry eye. But if you have hit number one occur in the setting of genetic susceptibility or this big black box that we're all trying to figure out, particularly here with our esteemed colleagues who are really going to make a difference in trying to determine what that black box is the cerebellum and cerebrum input. So the brain's input is a potential susceptibility that already exists when you end up with your eye surface disease. Now, again, we don't know the direction that this goes in. Is it eye surface disease that then changes? So does it go in the other direction and then change some of the hyperexcitability that we're seeing in the brain? But just assume for a moment that there really is these two hits that take the place. So if you have disinhibition, less inhibition from the cerebrum, you have a greater trigeminal response with eye surface disease. Ultimately, what you'll see is a greater facial nerve response, a stronger orbicularis oculi closure that's more frequent. And so this is really the focus of the talk, is to talk about that hit one, the eye surface disease. By far, eye surface disease does not appear to be present or symptomatic in everyone with blepharospasm. That's why we can't say that's the only sort of trigger, that's the only hit that's there. But it's becoming useful to use in mouse models, for instance, because it's the easiest one to sort of replicate. But if we look at some studies, multiple studies, many of the people in this room participated in those, we see that at onset about anywhere from 40 to 60% of people will have eye surface disorder symptoms. And only about 14% of those with hemifacial spasm in one study done in 2005 by Martino and others showed that they had eye symptom disorder or eye surface disorder symptoms. So a similar condition of facial spasm did not have as high of a number of symptoms. And most of those who have symptoms at the onset of blepharospasm will have symptoms 1 year prior to onset. And in my neuro-ophthalmology clinic, I'll see that frequently. Someone who even develops a unilateral case of the condition I said I wasn't going to talk about, but keratoconjunctivitis, who then develops sort of unilateral blinking and strong spasms, and then develops a case of blepharospasm within a year. Somebody I just saw last week. So we know those types of events can happen, and we think that that time period is what's critical, potentially between the ages of 40 and 59, for instance, with that background that makes somebody susceptible. So another interesting piece of information that we have from epidemiological studies, particularly DeFazio's group, as was already mentioned, is questions that are highly predictive of eye surface disorder. And those are listed here. And there's 4 questions. If you answer one, you have a greater than 90% chance, at least in the small study, of having eye surface disease related to patients with blepharospasm. Do your eyes feel dry, gritty or sandy sensation, burning sensation? Are your eyes ever red? And although we don't have a tremendous amount of data to say, is it possible that the blepharospasm itself is what's causing some of those symptoms, we are now at least able to separate it slightly with some of the data that we have to say that it's not all of your blepharospasm that's creating those, what we term eye surface disorder symptoms. And I want to add a few more besides those 4, which is increased tearing, a flakiness or redness of the lid at or around the eyelashes, and then blurred vision, of course, when you have dry eye and it starts to affect the cornea, which is what we use to focus our eyes. Once that becomes affected, you're going to have blurred vision. So let's look at the surface of the eye before I talk about those surface disorders. So we have the lacrimal gland, very important for producing the aqueous component of the tear film. That's the most voluminous, the watery component of the tear film, and that's produced by the lacrimal gland. But meibomian glands are extremely important in preventing that aqueous component from evaporating. They produce more of the oily and waxy and cholesterol components of the tear film, and those sit along the inner surface of that eyelid near the eyelashes. But also, there's a mucinous component to the tear film that helps keep surface tension normal so that the tear film is spread throughout the eye in a manner that's equal in one area of the eye and the other, and that's in the conjunctiva. It's a membrane that sits over the sclera, or the white part of the eye. All of these are extremely important in producing normal tear film. So again, I'm only going to be talking about dry eye and blepharitis because of their importance in benign essential blepharospasm. But you can have other conditions that beyond these that irritate that surface of the eye and cause increased blinking. So I'd like to sort of divide dry up into causes and culprits. Why? Because causes really get to the mechanism of why an eye is dry. And cause low production of tears, that may be the first thing that we all think about is, I'm just not making enough tears. But the quality of the tear film is extremely important. So poor quality and increased evaporation, extremely important to creating dry eye. And in fact, there's now I really call it a congress of ophthalmologists who are really studying and trying to understand meibomian gland dysfunction. Because if the oily component of your tear film is abnormal, you're going to have increased evaporation. You're going to have an abnormal surface, and therefore dry eye can occur. And meibomian gland dysfunction is actually quite common from a number of disorders, not just from one. So meibomian gland dysfunction can be related to blepharitis, but it also can contribute to dry eye. So remember those three components. They're very important. Now, culprits. Here we have beautiful Great Sand Dunes National Park in Colorado, and I highly recommend it. But these drops you're getting today will be very handy if you go there, because climate is extremely important. We see a lot of dry eye in Colorado. And just to give you a general idea, 7 to 10% of, in the United States is the incidence of dry eye, or I should say the prevalence, of dry eye. So we know, obviously, that not everybody with dry eye is going to end up with blepharospasm. It has to be that second hit that we've been talking about. Medications, very important. Chronic allergies, autoimmune disorders, eyelid infections, ineffective blink or decreased blink that we sometimes cause when we give you Botox or Botox derivatives, or other brands, I should say. So it's very important to think about all these culprits when you're trying to treat your dry eye, and that your physician concentrates on what the causes are. So you know the causes, you have to treat the causes, and you have to identify the culprits as well. So how would it be diagnosed? When you see your ophthalmologist, a careful examination to look at the surface of the eye, not just the cornea, which is extremely important. That's the one that has all the sensory nerves on it that you really know when something's in your eye. It's really about the cornea in terms of the blink reflex. And the eyelids, though, can have extreme contributing factors to your dry eye that I mentioned. Now, your doctor may or may not do routine or special stains, but they may be very important to figure out the cause. So you may measure how fast your tears break up. Again, recalling that lipid layer is important for preventing evaporation. And they want to assess for breakdown. This is an example here, the bottom picture of staining in the front of the eye and the cornea where there's been some breakdown of the cornea. And your doctor may also want to measure tear production. Again, does the lacrimal gland is it not producing enough aqueous volume for your tear film to stay healthy? So treatment. First, address the culprits. Extremely important. There's a long list of medications that are commonly used. Opiates for pain, antihistamines for allergies that can dry your mucous membranes, including the eyes. Adding lubricants is usually the mainstay of treatment, artificial tears. When things become severe or in the right instance, you can add plugs to prevent your tears from draining down your lacrimal duct. Autologous tears, is a difficult and time-consuming thing to get, but in the right circumstance, it will help the right patient. It is your own blood turned into a formula that you can put in your eye that likely has a makeup that allows your eyes to stay protected from dry eye conditions, or a condition that doesn't allow you to treat and decrease the culprit or decrease the cause. So in the right circumstance, although time-consuming, autologous sera is very important treatment for some patients. Improving your tear quality and decreasing evaporation, Meibomian gland dysfunction treatment, we'll talk about that briefly. And then improving production. If you have a decreased production, there may be ways to improve that. And then treating any known or presumptive inflammation with anti-inflammation eye drops. So those are the mainstays of treatment, and they vary for everybody. What about blepharitis? You've heard that mentioned a couple of times. What is that? Well, it's an eyelid inflammation. Particularly important is where that eyelid inflammation is, and that's going to be at the eyelash regions. That gives you the diagnosis of blepharitis. You can have an anterior variety, which is going to involve the eyelashes. In that bottom picture there, you can see a patient of mine with pretty severe anterior blepharitis, a lot of debris along the eyelashes. But posterior blepharitis is extremely important because that involves Meibomian gland dysfunction, and we've already heard about the importance of that in producing a healthy tear film. Common causes overlap for both anterior and posterior conditions, and as you saw, can contribute to dry eye too, and they include bacteria or other types of infection, dandruff, rosacea, a skin condition, allergic reactions, and autoimmune conditions. Now, treatment, again, is going to vary. It's going to depend on your particular case, but frequently antibiotics are given, topical or oral, or anti-inflammatory agents, depending on that main cause. Or multiple treatments may be occurring simultaneously. Warm compresses with massage and lid scrubs is really the mainstay of what you can do at home to treat Meibomian gland dysfunction, and we often prescribe that for home treatment. So I'm going to talk about what you can do at home if you're diagnosed with posterior blepharitis and Meibomian gland dysfunction. We already mentioned those warm compresses with massages twice a day, but gentle lid scrubs. This can happen or be helpful in anterior blepharitis as well. You can buy kits, but you can make your own at home with a washcloth or a cotton swab, very dilute soapy water, maybe a drop of baby shampoo in a cup. And then omega-3 fatty acids and flaxseed oil can contribute to improvement. Now you can see on the left, we want to turn this posterior blepharitis condition into the one on the right. You see the Meibomian gland secreting abnormal secretions, where on the right, you can barely see the glands. They're sitting here and they're healthy and they're secreting normal secretions that help your tear film stay healthy. That's the goal of treatment of posterior blepharitis. So it's often not just up to what the doctor prescribes, but there are things you can do at home as well. So, treatment of eye surface disorders. If you have blepharospasm, it's important to make that diagnosis, particularly if you have those symptoms that I spoke about. Have your eyes examined for that. And then continue to follow up, because recurrence after treatment is quite common, unless you really can address and get rid of the culprits, which oftentimes we can't. So do we know if treatment will decrease the severity of your orbicularis oculi spasm and blepharospasm, not just the symptoms? Does it actually decrease the spasm? Unfortunately, we don't have enough data to say that for sure, but we know that symptoms of ocular discomfort will improve, and potentially your symptoms of blepharospasm and the actual contraction of the muscle. So in summary, eye surface disorders may have a role in the development of blepharospasm. Certain symptoms are very predictive, you heard those that I gave you today, of the presence of eye surface disease. And diagnosis and treatment really requires a careful examination and likely improves the symptoms of benign essential blepharospasm, but in the least will improve the symptoms of the eye surface disorder. And I also want to point you to the Benign Essential Blepharospasm Research Foundation web pages. They have excellent videos, particularly about eye tear films. and handouts that you can read that are wonderful resources about eye surface disease, or ocular surface disease as we tend to call it. So I highly recommend those web pages. And thank you for your attention.